speaker today, Dr. James Cimino, you've read his bio. I hope you did. I'm not going to read it back to you, right? He's a board-certified internist and clinical informatician, and he's currently professor of medicine and the inaugural director of Informatics Institute at the University of Alabama, Birmingham School of Medicine. So he's been carrying out clinical informatics research for around 30 years. He doesn't look that old, but that's what he says, right? He's an early developer of methods for linking knowledge into electronic health records. And he's had previous appointments at Columbia University School of Medicine and also at the NIH Clinical Center here for a number of years. And he's co-editor with Ted Shortliff of the leading textbook on biomedical informatics. I was going to bring it and heft it for you, but I didn't want to have to carry it. It's a wonderful book. If you haven't looked at it, you should. Lots to learn there. His honors include fellowships of the American College of Physicians, the New York Academy of Medicine, the Donald Lindbergh Award for Innovation in Informatics, and the President's Award, both from the American Medical Informatics Association. And he was elected to the National Academy of Medicine. So he's published more than 250 peer-reviewed papers in the areas of biomedical terminologies, novel clinical information, and clinical research informatics. His paper, Desiderata for Controlled Medical Vocabularies in the 21st Century, has been cited more than 300 times and has a relative citation ratio. All of you know what that is, right? That's the NIH way of looking at things, of 12.4, which says 12 times as many citations as the average NIH article from the collection of similarly supported work. His topic today is transforming electronic health records from annoyances to assistance, a research agenda for the next decade, something that matters to all of us a lot. So welcome, Jim. We're looking forward to hearing you.
Thank you. Thanks for that nice introduction. So the last time I spoke here was about 30 years ago, and I must have done a good job because they invited me back. So I was here for about 7 years building a repository of clinical research data, mostly from the electronic health record data here at NIH, going back to 1976. And when I started trying to reuse it for research, I realized that there was a lot of problems with the content of the record that were going to make it hard for me to do my job. And I started thinking about what those things should be. And I've spent the last couple of years trying to figure out how to articulate that. So I'm going to give you some of my ideas today. I hope Patty Brennan is listening because this is really a talk for her, because I'd like to see the NIH pursue some of the research topics that I'm going to talk about. And NIH certainly has been the leader of informatics research thanks to Don Lindbergh's leadership here in informatics, clinical informatics research. The other institutes could definitely take a lesson from NIH, and I hope maybe they'll be listening in too. Okay, so what am I going to talk about? I'm going to talk about my vision for electronic health records. Everybody has one of those. I'm going to back mine up a little bit, but I'm going to start with a brief history, how we got into this mess in the first place, and then provide what I hope is a practical roadmap for getting us to where we should be. And in that, I'm going to include an agenda for the kinds of research topics I think we need to explore if we're really going to get there. Because I don't think we're going to get there by the current method, which is take really smart people and tell them there's a problem with electronic health record and tell them to fix it. And they do great stuff, but it's not getting us any closer to where we want to be. So I'm going to cover this time span. If you can see that, yeah, you can see the timeline at the bottom there. Okay, so there was another slide that's gone. So I'll have to tell you a little story. Oh, here it is. Okay. Patient comes into the hospital, is here for cardioversion. And she came in with palpitations. She's noted in the emergency room to have atrial fibrillation. The doctor does a cardiogram, sees there's atrial fibrillation, says, okay, how long you had symptoms? Patient says, oh, I've been fine, I haven't had any problems. And so they go to do cardioversion, and the system does this. It says, you ordered cardioversion with indication atrial fibrillation for Ms. Ann Smith. We inferred she has clinical stable atrial fibrillation, symptom duration greater than 48 hours, no evidence of anticoagulation during this prior month. And then it says the recommendation is that she should be anticoagulated for a month prior to cardioversion. So the system stopped the cardioversion which is good because if she had prolonged atrial fibrillation, she might have a clot in the atrium of her heart, and then when they get the heart going again in a normal rhythm, that atrium will kick that clot out and it'll do something bad to your brain or your lung or something like that. So what did the electronic health record know? In order to do that, it had to know that the symptoms started a month ago. It also had to know that the symptoms were related to the diagnosis. It's not something we typically put in our records today. It had to have some inference about the temporal aspect then of the diagnosis. It said, hey, if the symptoms started a month ago, maybe the diagnosis started a month ago. And then it included this guideline for cardioversion that it was actually able to make use of that information. But how did the EHR know that? Somebody had to tell it. Somebody had to put that information in explicitly into the record in one form or another so that the system could then make the inferences it needed. All right, so this is a photograph of the late Larry Weed, who passed away earlier this year. This is from a video of a lecture that he did at blanking now, Baylor, or I'm blanking on where it was. But you just go Lawrence Weed and problem-oriented medical record on YouTube, and you'll find this video, and it's really worth watching. He really rips into the residents who are writing the notes in that record he's holding. And so Larry started out with these papers, a pair of papers in 1968 in the New England Journal of Medicine, medical records that guide and teach. And those records, in those papers, he analyzed what kind of information is in electronic or paper records at the time, and what he thought should be in there. So this is an example from the paper, and it just says, well, the patient got some insulin because the blood sugar was this, then he got some Amgen yesterday, was febrile, up all night, et cetera, et cetera. The next day, some other things, vomited green fluid, and so on. So kind of a diary, telling what was going on with the patient. But Larry said, don't just record what's happened to the patient. You need to record what you're thinking, okay, so that the next person that picks up the record knows what's going on, knows how you think all those pieces fit together. And that's where the problem-oriented medical record came from, is a way to formalize a representation of what you think is going on with the patient and what you're going to do about those problems, not just what you did about them after the fact. And so that really started a change in the way we recorded information in paper records, and to a certain extent has carried over into electronic health records, but not in a way that is as useful as it could be. Okay, so electronic health records started because we had paper records. And so what we did, we said, well, now we've got a computer. Let's take these paper records and computerize them. And so we did what we typically do when we apply a new technology to development. Think about the horse-drawn carriage and then think about automobiles. And we had horseless carriages. So they basically were the same technology as the horse-drawn carriage. We just replaced the horse with a motor. And so then, we started thinking about how are we going to make these things better. But what we started with, though, was this electronic diary, mostly for billing purposes. And so we have this record of this patient that says, okay, we have a history, we did a cardiogram, it shows atrial fibrillation, there's an impression and plan in here, there's some orders, but what's not in here is, for instance, saying, well, why did I order the digoxin? Am I giving it for the atrial fibrillation? Am I giving it for, why am I doing a thyroid function test for a heart disease? It doesn't tie it all together in a formal way. It's all in there in the text, ideally. In fact, if you look at records today, you'll find a lot of this is not in the text, that people are so busy making sure they've got all the pieces of things that they're required by law to have that they don't put their actual thinking in the record anymore. So we have these orders and so on. All right, so now we have our first version. We had to start someplace. So what do we do? Well, what did the auto industry do? They started with horseless carriages, and they built better horseless carriages. Okay, and so that's what our EHRs are today. To a certain extent, they're better horseless carriages. And so, there was a report to the president by the President's Science Advisory Committee that said we should have a committee to establish a national health record. And that was 1963 when that was done. No committee was established for 50 years or so. Now we have the Office of the National Coordinator, and we have promulgation of health records, and to a certain extent, further development of those records into what I could call the third generation electronic health record. So that first and second generation was really more the free text stuff. The third generation, now we've got this, some of it's structured and some of it's coded. So the things that are in bold are the coded structured things, and then the things that are not in bold are the free text. So we've got fields now in the record. You say, okay, you want to see the history, that's where you go look for it. And then there's a bunch of text. Some of the stuff is structured and coded, like the vital signs. Okay, so we say we've got a heart rate, and it's got a value, 125, and then there's irregular. Maybe that's a free text modifier. Maybe it's a choice from a pull-down menu. We've got a problem list, and maybe we have a controlled terminology on the problem list. And then we look at the orders, and those are often controlled because we need to communicate them to some other system. So we have a drug order, we have an echocardiogram, blood tests, so on, and those go to their respective ancillary systems. And so there, at least, we have a chance of capturing things using a controlled terminology, so we can do some interesting things with them. But what we see, for instance, the differential diagnosis is still in free text. And you're lucky if you find that in the record, but when you do, it's never in a structured thing where they say, okay, pick some SNOMED codes to say what your differential diagnosis is. We don't do that. So that's kind of where we are today. And what we end up with is annoyances from the record. So one problem we have is that the data is kind of scattered around in different places because we're not modeling the patient. We're modeling the events of what happened to the patient. And so some things happen in the outpatient, some happen inpatient. This is just an example of some data I pulled from a patient record of all the medications, and some of it was their outpatient medication, some of it was a note, some of it was a discharge summary from it was the admission note, some of it was the orders when the patient was admitted, and we have all these different medication lists, and then we need to try to figure out how to reconcile those. And so we put that on the physician, and we say, okay, go look at the record and tell us the exact list of medications that patient should be on. And by the way, tell us why you're not continuing all the records, all the medications that were elsewhere in the record. And we don't give them any tools to do that. We just say, here's the record, make a list. Another annoyance. So this is some instructions that I saw recently for how to use electronic record system for ordering things in between clinic visits. And so these are some instructions. Use your last clinic visit to place orders. Use a location associated with your clinic. This ensures the task goes to the appropriate task in your clinic. Make sure you recheck. Check retrieval additional encounters to see discharged encounters. If the patient needs to return with labs and radiology, you can launch orders from the message, and the orders will be pulled into the message the scheduler receives. If the patient has been seen before, a message can be sent to your scheduler using the documentation encounter. Please include any details needed for pre-certification. And I guess you need to know what those details are. So this is fine set of instructions if your job is to sit in front of a computer all day and do order entry. And this is what you're going to do. Maybe you could figure this out. But if your job is to take care of sick people, figure out what's going on with them, tell them what they need to do, and then put something in the computer to get the computer to help them, having to know what this even means, let alone how to do it, is a little overwhelming. Let's have some more annoyances. So we have our record. When we reorder a drug, we have the alerting system. Okay, so those have been around. Alerts have been around since the late 60s, and we're still having trouble with them. So the alerts tend to generate a lot of stupid alerts. That's the SpongeBob character. So 80%, maybe more sometimes, of the alerts are stupid in the sense that the computer says you should do this, and the physician says, yeah, no, I'm not going to do that. And then 20%, maybe if you're lucky, are the ones that are going to save the patient's life. That's the Superman icon. So we have to override the stupid ones. Make sure we don't follow them because we know something the computer doesn't know, and so we have to override them. And then, unfortunately, we also override the smart ones sometimes because we're so busy clicking through these annoying alerts that we end up with alert fatigue and we don't pay attention to them. So that's a real problem. So then we start adding more things to the record. So let's put in progress notes. And then it's a barnacle that we just slap onto the, we had this billing laboratory system. The progress note is an extra piece. Then we do medication reconciliation and adverse event reporting and discharge orders. And we start adding all these pieces to the record that aren't integrated with each other. They each require their own data to be entered into the system. And so we end up with something that is just covered with these barnacles. You can't actually see what's going on. This is a series of statues outside off the coast of England that get covered up with high tide. I thought they made a nice depiction of how we often feel when we're dealing with these systems where everything is just another disjointed piece that we have to work with. All right, so what if instead of natural evolution, we had intelligent design of the electronic health record? And let's imagine a planet where there's no trees, so there's no paper records. And so somebody says, oh, you know what, we've got computers and we've got this healthcare problem. Why don't we figure out how to make the computer do what we need to take care of the sick people. And then, so instead of saying, well, let's build a diary, that's a good idea. No, we would build something that was going to actually take care of patients. And so in the future here, maybe there's hope for us to achieve that. All right, so before we throw the baby out with the bathwater, let's look at some of the things these computerized patient records do well. They do billing really well, and they improve legibility, no question about it. That you can read these records much more easily than the paper records that a lot of us had to grow up with. They're available for the most part. Of course, there are problems. There are always problems, with computer systems, but the problems with paper systems are even worse. So it's very hard to back up a paper record system. It's even hard to find a physical chart sometimes when multiple people want it. And somebody's holding on to it because they need it to present in rounds the next morning, but meanwhile the patient's having a problem and somebody needs to see it. So the electronic one's much more ubiquitous. Result reporting, they do that pretty well, and that's one of the things that they've been doing since the beginning, is getting data from a laboratory out to a place where you can see it without having to call the lab or go there to get the answer. And they do order entry to the extent that they do communicate things automatically between systems so that at least things aren't falling through the cracks. And they do these alerts and reminders. They can be really good at that. Now, what do they do wrong? Well, the first thing on the list is alerts and reminders. They don't do those as well as they could, and when they are over enthusiastic, we get this alert fatigue, which is then a dangerous problem. Data entry is still very tedious. We do a lot of redundant data entry. So, for instance, in the medication reconciliation, typically you have to put in all the medicines you want the person. You can't just go, oh, I found this over here and over here. Let me drag these things in and just create the list from all the other data in the record. They are often incomplete. They're incomplete because we have gaps in the patient care, or the patient is getting cared in multiple places, and so the record we have doesn't always have everything we need to know about the patient. Despite that, we end up with note bloat and data overload because we do bring in a lot of things and repeat them over and over again, and it gets a little overwhelming. And I don't know if you have occasion to look at medical records and see the notes that the house staff write. I'm still getting used to, I've been at UAB for 2 years now, and I'm still trying to get used to figuring out where's the actual information in this really long note. And you can't see the whole note, of course, because you got to scroll on the screen, and there's a lot of stuff that's boilerplate that's been copied from other notes and copied from other parts of the record, like all the labs are in there, and trying to figure out where's the part that the person actually added where they said what they were thinking. It's very hard to find. So navigation's a problem. We still have this notion that a record is chronological and organized by department. And so I want to say, well, find me all the labs, and it'll show me the labs. And if I want to say, well, show me the labs with the medications and how those fit together, there's no hope of doing that. Even worse, the systems we have today are all based on billing systems. And so a lot of times when you go into the record and say, show me the patient's information, they go, well, which visit are you interested in? And I'm like, I'm interested in the patient. I want to know everything across all the visits. But the data has been partitioned by visit because that's how the billing is done. Okay, so what could they be doing? And there's a long list of these things. And actually, you go to the AMIA Fall Symposium next week, and you'll hear a lot of ideas when that's been going on for now 30-some-odd years, that people have been coming with good ideas that we could be doing with this, but a lot of them die on the vine because we can't find ways to bring them into the clinical setting. So first thing we want to do is minimize the annoyance. Physicians are dropping out of practice, telling their kids not to go into medicine because they can't stand the medical records, the electronic medical records. I got to find an ad for this. I've seen it. I need to add it in my talk. It's an ad for a hospital that is recruiting physicians, and their big attractor is, we do not have an electronic health record. So seriously, I've got to locate that because it's pretty telling. Okay, we need a system that will tell us what's going on with the patient. Not just, here's everything you need to know, but tell us the story, tell us what's going on. We need to educate the users of these systems so that as we build better tools in there, they know what is actually going on with the tools, so that they are not constantly going, well, why is it asking me this question? I'm just going to answer whatever way I can, because they don't know what it's supposed to do once they answer the question. So those users are not only physicians and nurses, but other healthcare workers and the patient's family members. And we make it assist with patient care. If you think about what we have when we're in the hospital and we have a physician, we have a resident, we have medical students, everybody kind of knows what's going on with the patient, and they get a task and they go off and do it, and using the knowledge and skills that are appropriate for their level. We need the computer system to be able to do that too. And we need to support research to figure out how to do all these things. What are these things, and what's the best way to go about doing them? All right, so what's missing? number of things that I think, as I thought about what is it that I need to have in this record that will allow me to do the things I really want to do. First thing I thought about is something that a number of people have been talking about, situational awareness. And this comes from aviation, actually, as the idea of knowing what's going on around you, not just the specific task, but knowing the context that you're in. So situational awareness is being aware of the bigger dangers that you're encountering, not just your specific immediate needs. And so the first paper I found on this that related to medicine was in 2006 by Singh, Peterson, and Thomas, and they were talking about how diagnostic errors often come about because we don't have the situational awareness of the patient. Another one is causal reasoning. So causal reasoning is the ability to say, well, if I know X and Y, I think I can understand why, if in a patient's case, patient has this gene and they have this lab result and they have this exposure, I think they're going to have this disease. And so causal reasoning goes back quite a ways. This is a paper by Kaz Kulikowski and Pete Sullivan's book in 1982, but Kaznet goes back even before 1982. And this is a diagram of a causal network for a very small part of the body for one disease. It's an eye, and it's glaucoma, and this is 1982. I'm sure it's more complicated now. So causal networks will be challenging to figure out how do we build things that are going to actually be usable and scale. And what I really like about this diagram especially is that that this is a simplified causal network. Okay, so it's a challenging problem to figure out how to do that. Another one is the formal representation of clinical cognition. That is, what are the actors thinking? What is the doctor thinking? What is the patient thinking? What are the patient's priorities? What are the doctor's priorities? How do all these little pieces of data that we record in the diary fit together in some coherent way? And so by that I can talk about the representation of symptoms, exam findings, interpretations, differential diagnosis, and maybe other things as well, and how they relate to each other. So the example of a symptom being tied to a physical finding and so on. And I have a little diagram of that. And then the preferences and priorities, so that the system knows if the patient has two problems going on, and one's myocardial infarction and one is poison ivy, which one's most important? Well, it depends. If the myocardial infarction was 6 months ago and uncomplicated, but the poison ivy is going to require IV steroids, we actually want to pay more attention to the poison ivy. So knowing something about those priorities is important. Right now, the problem list is just a flat list of things. What can we afford not to miss, and what's okay to ignore, so we can have those alerts shut up once in a while. So, in your middle of a code, it doesn't say, this patient hasn't had a flu shot yet. You might want to do that while you're, doing these other things. So we need to be able to represent it in more formal ways. So with that, I think about what would I want if I was starting from scratch. What would I want in the electronic health record for my 4th generation EHR? Well, first, the data that I'm going to put in are pretty much the same. So I'm going to capture data about the patient's demographics, the symptoms the patients had, palpitations, shortness of breath. I go and do a physical examination, and I find a number of different things. I find, for instance, that the heart is irregularly irregular, the pulse is irregular, and then I can start to think about, okay, so I've got this patient has these symptoms, the patient has this physical exam, and my impression now is going to be that the patient has an arrhythmia based on, at least on the physical examination. But I might say, this arrhythmia might be explaining the shortness of breath and the palpitations, so I can tie those together explicitly. Then I say, okay, now I need a differential diagnosis for the arrhythmia. My first thing I'm going to think of is atrial fibrillation because of just the irregular nature of it. And so I'm going to use a cardiogram to make diagnosis. And when I do, it confirms that the patient has atrial fibrillation. So now I'm representing the relationship between the finding on the EKG and all the other pieces of this patient's record. And then I can say, okay, not only is it explaining the symptoms, it may also be explaining these physical findings. So now I can say all that stuff that we came in, those were all the things that were the patient's problem. I'm going to associate them with the atrial fibrillation. If I fix the atrial fibrillation and any of those things are still going on, then I've got to rethink that explanation. But meanwhile, I can kind of partition that task off and focus just on the atrial fibrillation. So I'm going to treat atrial fibrillation. I'm going to give digoxin or some other therapy. And I'm going to monitor the digoxin level, and I'm going to order vital signs. And the system can do all of that because it knows that I'm treating atrial fibrillation. It says, you're treating atrial fibrillation, here's what you should do, give me an order set. And we do those now with order sets, but they're not tied into this whole network of cognitive reasoning. And then again, we've got our vital signs tied back to those findings. All right, now I've got a patient with atrial fibrillation, and I'm controlling the rate and maybe improving the symptoms, but now what? I've got to figure out why this patient has atrial fibrillation, and there's a lot of different possible causes. It could be hyperthyroidism, pulmonary embolism, it could be mitral valve disease, lots of different things. So I'm going to order some tests that will help me discriminate them, thyroid function tests, echocardiogram, to figure out what's going on. Now my system has all kinds of wonderful warnings so that I don't over-order tests. So if I ordered a thyroid function test a couple of weeks ago, the system might tell me, hey, you know what, don't do thyroid function tests, you've just done them recently. But I can say, you know, I did those before the patient had the atrial fibrillation, and maybe there's been a change. And so we could actually suppress the alert because we know that it's not relevant in this particular situation. Okay, so we do the thyroid function test, we find out the patient has hyperthyroidism, and then we go off and the system goes, okay, here's how you work up the hyperthyroidism now, here's how you treat the hyperthyroidism, here's how you treat whatever with the cause of the hyperthyroidism. There's a whole path that goes along there. We've still got this atrial fibrillation, and we'd like to get the patient out of that rhythm. Okay, so what are we going to do? We're going to treat the patient with cardioversion. So we order the cardioversion, and then that's where we get that alert that I showed at the beginning, because the system says, wait a minute, this patient's disease may be of more than 2 weeks duration because the symptoms you told me you think are due to the disease have been going on that long. So now we can issue an alert that blocks that potentially life-threatening medical decision. Okay, and then so what else? We want to represent more than just the tactics. The tactics are the things that we order. The strategy is what we're really trying to do. So I use this diagram to kind of display it. This is my son playing with a giant chess game, and tactics are the action or method for a plan to achieve an immediate particular goal. So you'll see my son moving the pieces around, or any chess player, and you know, well, he's trying to get a better position, he's trying to do this, trying to take that piece, but you don't really know what his overall strategy, the plan for achieving a goal over a long period of time. You don't get that from the individual moves, and we don't put that in the record. In my son's case, it was world domination, and it didn't become immediately apparent. But we don't put this explicitly in our record. Okay, so representing this situation, I want to represent aspects of this. How do I do this in some formal way? I say symptoms related to findings. Findings suggest differential diagnosis. Test to confirm the diagnosis. Test supports diagnosis. The diagnosis explains the finding. Therapy treats the diagnosis. Therapy prevents diagnosis. And we represent the patient's state in some formal way. So actually, the classes of things I'm talking about are relatively small here. Test, diagnosis, therapy. And the relationships are relatively small too. And this very limited ontology, if you will, might be sufficient for doing a lot of things that we want to do in the record that we can't do now. Okay, so if we do this, the system can start the workup for the hyperthyroidism. It can bring just-in-time knowledge with info buttons because it knows now what questions I'm likely to be asking. It can identify the goal. So, for instance, when we want to anticoagulate somebody, the degree of anticoagulation we choose depends on the reason. So the system now knows the reason. It can bring up the appropriate guideline. And maybe it can also say, you know, you better, before you do this anticoagulant, you better do a pregnancy test because this anticoagulant is contraindicated in pregnancy. It can tell us about the role of genetics in choosing the drug or choosing the dose and bring that to bear on the problem. And so we can have this personalized goal-based drug selection and dose algorithm. And then establishing the plan for cardioversion, which includes, well, if you have to monitor the anticoagulation, you do that. Make an appointment, follow-up appointment, give the patient instructions, send the patient an email right before tell them not to eat. You know, whatever it is that you have to do, the system can do all that because now it knows what you're trying to accomplish. And the last thing, we're going to ask clinicians to put more information into the record. There has to be some kind of payback to reduce the data entry to compensate for that extra effort we're going to require of them. And I think that if we do this right, that the system will be able to write the note at the end of the day. And I don't mean write a note, I mean write the note. So it now knows, if it knows everything that everybody's doing, it can write a note that talks about the patient, not just what I think about the patient, but what's going on with the patient. And wouldn't that be nice if at the end of the day you had somebody come in and read the whole record and write one summary so that the next day you could read that one note. So it pulls all the history in. A lot of that's from the orders. But my impression could be noted as I add that extra information about how I'm tying different things together. And then my plan, treat the atrial fibrillation to improve the patient's symptoms. That's my plan. And then I'm going to evaluate the cause of the hyperthyroidism and perform electrocardioversion and so on. So it can actually, I think, generate this. Now, text generation is easy. Text understanding harder, but text generation actually is pretty easy to do if we have all those pieces in place. Okay, so great. We come up with these ideas. What do? We're stuck with these electronic health records that we spent literally billions of dollars putting into place. And so do we rip them out and start over? Maybe we don't have to do that. My thought is that we can start with a simple black box that's basically some kind of a document that we store in the electronic health record. So the EHR, it's really good at storing data. It really controls who gets access to it. It makes sure it belongs to the right patient. It keeps track of who's looking at it. It doesn't know what those documents are a lot of the time. They're letters from outside, they're laboratory tests, whatever, it stores them. And it gives them back to you when you need it. So let's figure out what this thing should be, and then let the EHR store it for us, take care of it. And we could use FHIR, the Fast Health Interoperability Resources from HL7, as a way to exchange documents. It does that now, very simple. Okay, we can pull data from EHR tables and use that to help us populate what goes in the black box. And what's in the black box is some kind of knowledge structure, an RDF or an XML document or something that captures all that knowledge that we want to represent. We can enhance it with other information from the EHR, and then we can build apps, including smart apps, the substitutable medical applications, reusable technologies, but apps that could then make use of this information to do things like say, hey, here's the right anticoagulant to choose for this patient based on everything we know, and then be able to add that to this knowledge structure. So Smart on FHIR, kind of glossed over that, but Smart on FHIR is the popular way of combining those acronyms. All right, so this is one approach, and the metaphor I use is the Parasitism Metaphor. And so if you think about, where are we? Think about a fig tree. So fig tree starts off as a vine. It's fairly innocuous. It's a little vine. It grows up around a tree. But eventually, it grows around the tree and actually replaces the tree. It kills it. So this is one possibility, is that we build lots of these smart apps, and eventually we just get rid of the EHR itself. This is not a popular idea with the EHR vendors, of course, but it's one way we could move forward. But I'm thinking about a different way, which is to actually empower the EHR to get at what's in that black box. So we have decision support in that system. The decision support could be smarter if it had access to that information. So we put that in some kind of a table, an EAV table or whatever, that the EHR then, its decision support can get access to it and start to use that as part of its own function. Now, we don't let the EHR change it, at least not initially, because we want to control what's in there, but the EHR can use it in a passive way. But then we can move on to mutualism, where we actually have the EHR actually taking on these functions. And the metaphor I like to use is this one. So this is an electron micrograph of a cell, and it's infected with bacteria. I don't remember what the bacteria are, but there's a bacterium. It also has other structures, organelles, and one of them is mitochondria. And you may not know, mitochondria are these organelles in all of our cells that were originally free-living bacteria many billions of years ago. They were free-living bacteria. They infected some prokaryotic cell, and they survived inside the cell, and they provided a function. They provided energy in the form of ATP. And so the mitochondria have their own DNA, and they divide just like other bacteria. They can't live outside the cell, but they go on about their business. And the genetics of the mitochondria are fascinating because they've been passed down from mother to child through the ova from Eve on down. So you can do all kinds of interesting things with them. And so their genetics has been studied very well. And I was at a lecture talking about this, and they showed this genome, and I said, oh, is that the whole genome, or is that just like a schematic? And they said, no, that's the whole genome. I said, how could that be the genome for a thing that is a bacteria that divides and does all these other wonderful things? And they said, I don't know, I'm a mathematician. And so I had to go and look this up. And the first thing I found, of course, is that genomes of bacteria are very complicated, very elaborate, as you'd expect. And I'm thinking, well, what happened? How did this happen? Well, it turns out that as the mitochondria survived in the prokaryotic cell, it was able to shed some of its functions. It didn't need to make a lot of the proteins that it was making before, and the host cell started doing that. So the host cell actually evolved to provide functions from the mitochondria so the mitochondria could be more efficient at what it was good at doing. And so it's an evolutionary process, and I think maybe that's the kind of thing we can see our current EHRs evolve towards as we figure out how to define some of this clinical cognition that we need to add to the record. Okay, and so then the idea would be that the EHR tables would actually have this information in native form that the EHR could use. All right, so a research agenda. What do we have to do to get from there to, from where we are now to where I'm projecting? So first of all, we need informatics research on these deeper models. What is it that we need to do? And people have started working on this. So this is, let's see, this is a paper from recently, 2015, by Shen and colleagues, where they're looking at case-based reasoning and developing a cognitive model for case-based reasoning, which is actually pretty close to the kind of information that we would put in a health record. So you'll notice some of the bigger nodes there are diagnosis, prognosis, treatment, and there's patients, and there's administration schema, and there's all these other pieces that are all interacting. And so the ontology here may very well be a good founding first step in developing the kind of thing we want to represent in electronic health records themselves. Another one was a study that I've done, so far unpublished, but basically what I was looking at was what's the cognitive information that's in typical records, and if I can't find typical records that contain it, I thought maybe I could use New England Journal of Medicine case reports, because in the case report, they're talking about patients, they're doing all the same things that you would do in a health record, but they're actually explaining what they're thinking. So here's this one, for instance, the presentation of spontaneous bruising is most suggestive of a coagulation cascade defect. So the author has made a statement relating something the patient has with something the patient may have in an explicit way. So that's that differential diagnosis piece that comes up. And what I did was actually send a bunch of these cases divided up into individual sentences to a whole bunch of ACME members, American College of Medical Informatics members, and ask them to tell me what were the relationships between the concepts that were in those sentences. And we came up with a list of about 10 that kind of collapsed down into about 10 of relationships between these things. And maybe this paper will see the light of day someday, but you get a flavor of what's in there. There's findings explicitly stated as not present, so something is absent, and that's significant. There's a result of a clinical observation. Finding is present and supports hypothesis for some cause, and so on. And then there's some examples there. And I don't know if we can make these slides available, but people can certainly pause the video and read these at their leisure. This was one network that I created for one particular part of the case that uses all those relationships, and I'm not going to try to decode it, but here's the interpretation of the uppercase letters are the concepts and the lowercase letters are the relationships, and the little characters there are not. So no history of disease or disease not present, that's a not sign. That's how you interpret that. So you can go through again and read these, or I'm happy to share the paper in its current form. And then finally, or not finally, but another study by Ariane Javia and Ornstein, and I just heard they gave a talk last week at Children's Hospital of Philadelphia, talking about how they would represent the plan in a formal way that takes into account all the other tasks that have to happen, and including things with the problem list and symptoms and so on. So I think a lot of these pieces are starting to form. People are starting to say, you know, there's an area, there's a gap here that we need to fill in if we're going to make our systems better. I think we're starting to converge on that. So informatics research on deeper models. We need to improve data capture, new ways to capture data. And for that, I turned to my buddy, Tom Payne. And Tom had a paper that he's presented at AHRQ and has some papers in the works now. But his approach is to use a cell phone throughout the day so that clinicians get a message, they get a lab result, whatever, and they can just dictate that piece of the record, and it all goes into the record and then can be compiled into a single note at the end of the day. So using new technologies, new ways to gather this, that's less intrusive, less time consuming, maybe has a better chance of having more completeness. And then we've got to change education. So we've got to teach physicians and the nurses and patients what these systems are doing. And this actually came up, occurred to me when I was at Epic out in Wisconsin, and they were showing me this fancy thing they were doing with natural language processing, and they were pulling out all these things from the record, and they put them in a list, and then they put radio buttons next to them, and the idea was the clinician would go to those and say, then one column was for problem, one column was for diagnosis, and one column was for past medical history. And the idea is you would pick what those things were, and then it could store them in the record appropriately. Well, my first question was, excuse me, what's the difference between a problem and a diagnosis? And they said, we don't know, we're the salespeople. And so they said, we'll get the technical people to talk to you. And we never had that conversation. But I'm thinking, if you guys don't know what this is, and I don't know what it is, as an internist and as an informatician, what's the regular physician going to do when he sees this list? I know exactly what he's going to do. He's going to go, what the heck is this? Click, 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 click. Get this thing out of my face. I got patients to see. I can't be bothered with this. Well, when I got to UAB and I started doing training on this, that was, of course, the EPIC system in Wisconsin. When I got to UAB, we have the Cerner system, and they started showing me how to manage the patient list, and there was this thing, the problem list, and then I could move it to diagnosis, and I could move it to past medical history. And I thought, oh, this looks familiar. Let's see what this actually does. And so when I tried to move a problem to past medical history, it wouldn't let me do it. And I could only move a diagnosis to past medical history. I go, aha. So you can't, the past medical history is only about confirmed diagnosis. If you have a problem like chest pain, you can't say there was a past medical history of chest pain. So now I'm starting to get an idea of what the deeper model of this is, and maybe what the system could do with it. But I still have this problem now that if the physician just goes, oh, in order to put this on past medical history, I have to make it a diagnosis. Fine, I'll have diagnosis, chest pain unspecified, and I'll make that past medical history. We do whatever we do to get our jobs done, and we do a lot of end runs around these systems. And I thought about, this system might be doing something useful, but if the physician doesn't know why it's doing this, she's not going to do the right thing. She's going to click the wrong thing, and then the system is either going to fail at doing what it's supposed to do, or worse, it might do something wrong. So, for instance, it might say, oh, this is past medical history? Fine, I won't remind you when it's really critical to know that this thing is a current problem. So we need to make sure that we educate all the users of these systems, and it includes patients who are going to be contributing more and more to the record, so that when they put the information in, they don't just put whatever pops in their head. They put it in knowing what the implications are of what they're doing. Okay, so next generation EHR, we want better data entry, better user interface, both for searching and navigation, reducing redundant data entry, integrating health information exchanges so we can bring more information in, but not overwhelm the physician because we bring it in and organize it. We want smarter alerts and reminders that know what's going on with the patient, and just-in-time education for decision support, and then we can start looking at how do we have a learning health system. So the learning health system, of course, is the idea that we have all these records, lots of data about patients. We can go in there and draw inferences from what we see in the record. That was the thing that was frustrating me here at NIH with the records from the clinical center, is that I couldn't figure out what was going on with the patient. A friend of mine said, hey, Jim, I checked my B12 level and it's very high. What does that mean? And I said, why did you check your B12 level? She said, well, I thought I should check my vitamins, and I had access to testing, so I just did it. I said, well, now you have a problem because an elevated B12 level is a sign of some very bad diseases. But I don't think you have any of those bad diseases because you seem pretty healthy. And so I went to the system here, Beatrice, and I said, find me all the patients with elevated B12 and let me figure out how that relates to their disease. And I went in, and in 2 seconds, I had 5,000 patients with elevated B12. I said, all right, get rid of the patients that are taking B12 for some reason. I got rid of them. That was only a few hundred. I still had thousands of patients, and then I said, okay, now let me see what their problems were, how they related to the B12 levels, and then I can start to look at what is it that is maybe B12 elevation is going to predict the evolution of some disease. It was hopeless. First of all, most of the people had this one same disease, lymphoproliferative disorder, not elsewhere classified. Okay, so if you're familiar with ICD-9, that's kind of a garbage can diagnosis. So it doesn't really tell me what they had, except that I knew that a lot of the things in that garbage can are the kinds of things that raise your B12 level. But a bigger problem was that there was no information in the record where they said, oh, this B12 level is associated with this disease. And when I looked at temporal relationships, sometimes the B12 level would appear, but the diagnosis wasn't there, or the diagnosis preceded the B12, but then the diagnosis disappeared. So do they still have the disease? I couldn't tell because the records were too spotty. So our learning health system, if we're really going to accomplish this, where we can go in and say, when we give a patient a drug, does it really work, or did the patient have to stop the drug? Why did the patient stop the drug? That information is going to need to be more formally represented if we have any hope of using it. Okay, so the future. So we have our patient seen in the emergency room for palpitations a month ago. All right, so now we're back to our Mrs. Smith, and so it was a month ago she came in the emergency room. The system stopped that cardioversion, recommended anticoagulation, recommended follow-up, bunch of other stuff, and so she was on anticoagulation, and now she's back for her cardioversion. She still has atrial fibrillation, so now we can do the cardioversion and we get a good result. And here's our electronic health record of the future. And this is cardioversion of atrial fibrillation, and we can see the EKG, and it's recommending a book on warfarin and U that we could give the patient, and sort of a little play on what Amazon would do if we were letting Amazon build our electronic health records. Okay, so that is pretty much my talk. How do we spend the next 20 years of that research agenda? And this is where I hope Patty Brennan is listening. We want informatics research to model all these things. We can't build them today. We're getting started on some ideas, but we can't just go out and build a computer program that's going to do this, or we'll do it wrong. We need to look and model this carefully like we've done so many other things in informatics. So modeling situational awareness, causal reasoning, clinical cognition, and strategy. And then look at those models, figure out what would the EHR look like if we started from scratch, and start to build towards that vision so that we bring in things that are useful for caring for the patient, not useful for billing or for legal documentation and what have you. We need to find a way to manage the technology transition. We can't just build this stuff and expect it's going to get adopted. Those days are long gone in clinical informatics, and we got to remember to educate our stakeholders so that when we actually bring these things to bear, they know what they're doing, they know what their role is in using them, and they contribute to it rather than just fight it. So I talked too fast. I thought being in Alabama for 2.5 years, I'd start talking slower, but moving north for the day has sped me up. So there's time for questions. Thank you.
Who has a question?
Yep.
Hi, Jim. Thanks for the wonderful talk. So you suggested that the EHRs should be more aware of the situation and the context of the information that is being captured. So, and one example you gave is to link, for example, symptoms to a diagnosis. So how much do you anticipate that to be done in a smart way, meaning that no additional data entry by the physician, and how much do you think is the limitation of that approach?
So that's a good question, and I think it's going to have. It's clearly we can't just have the computer go, okay, you said he has this. Now, why do you think he? We can't have the computer quiz for each of those pieces of data. We probably can do some smart things with saying, oh, usually when this is found on physical exam, it's related to one of these problems, and maybe ask the physician if we can't figure it out automatically. Say, do you think this is from this, or this? Or maybe we can add some graphical user interfaces so we have a way of depicting these things graphically so somebody could just draw a line to quickly link things up. And I know I've seen some work by some of the EHR developers actually building user interfaces for their commercial products for future development that would take advantage of that kind of thing. I think that's a research question we need to answer. Clearly, we can't just demand that they write twice as much information into their record. We have to find smart ways to do that. And then I think there's some possibilities. Clem?
Yeah, so I loved it. I mean, that's where the world should be. And I think that's how some of us clinicians think when we write notes. But the challenge is, I mean, we hear we're going to get the data, patients can put it in. We did one study with patients entering a standard questionnaire, just a whole bunch of symptoms and findings. And it was like 5 times the density of symptoms as what the clinician would have pulled. Because you get a different answer when you say what's wrong versus do you have this, or this. So I think we need some research in that space to figure out what this data means when it's collected different ways. And
absolutely. Then that's the patient school idea. Is what if we taught patients how to give a medical history? Those of us who are physicians have probably had an occasion to accompany a family member and listen to the family member giving a history to the caregiver and just sort of cringing and going, oh, you used that word, and now the caregiver, the physician or the nurse or whoever, is going to be thinking you're having a heart attack when you really have some other thing. And you often jump in and even try to say, are you sure you meant this, or didn't you want to say it that way? If we taught patients how to give histories, how to think about their problems in a temporal way, and think about causative or exacerbating factors or whatever it is that we want to bring in, maybe the patients would do a better job. One of the things I think we could do is travel history. Patients know where they were. No amount of questioning the patient is going to make them, know more than what they know. So if we give them a where in the world was Carmen Sandiego thing and let them just show us their travel history, maybe there are ways we can capture that that's going to be more meaningful. it's a research issue, though. It's not something we can just say, oh, don't forget to teach the patient how to use this system. Don't forget how to teach the physician, or you'll get slides with instructions like I showed earlier. So I think that's part of the research agenda, is to figure out how to do that. But definitely a huge question. We can't just let the patients go, check off every symptom you've ever had. Then it would just be a solid line of symptoms, and we'd never get through it all. There was a question? Yeah.
So Google today is explicitly pushing for a reality where the interaction with technology moves beyond screens and clicks and taps. They call it the AI-first world, where technology surrounds us and adapts to us. So some technologies are maturing, such as speech recognition and speech generation. So my question is, if you have a vision for how the EHR of the future should interact with the clinician or with the healthcare provider as a whole, beyond dictating text to a computer or clicking on a screen?
Well, I'm just a country doctor from Alabama, but I think that there's definitely ways to bring new technology to bear on this. And, even some of the things like the simple Amazon example of sort of smart suggestions based on other information, but certainly other technologies are going to play a big role in this, and I think it's going to be up to those of you who are following behind me in the research world to start to address those issues. I think what we can do now is create a framework where that kind of information can be added without simply overwhelming. So, for example, I've got a Fitbit, all right, and I'm pretty sure that if we looked at Fitbit data, maybe somebody's already done this, but if you looked at the Fitbit data for patients with congestive heart failure and you followed them prospectively, that you would find patterns in those data that predict deterioration, which can occur over days or weeks, and can be very subtle for the patient and for anybody around the patient. But I bet if you looked at how much they're walking and how that's decreasing and how slowly they go up the stairs or whatever it can tell us, we would be able to predict things. We cannot bring our Fitbit records to our physicians and go, here's my Fitbit record, how am I doing? That's just going to overwhelm them. We have to figure out how to bring that into the whole cognitive milieu of patient care in a sensible way. So we could say, okay, we take this and interpret this into some pattern, and then that pattern becomes a datum that we then use for the rest of our representation. I think there's a lot of research needs to be done there as well. But clearly, there's a lot of things we can bring to bear, virtual reality, heads-up displays, all these kinds of things are other ways we can do data entry and also data display to people that are trying to, where we're trying to prevent them from getting overwhelmed. Imagine a VR glasses where, where you could see the patient's record and look around and you weren't constrained to a little screen or to scroll, but you could just look over and go, oh, I want to see what happened 5 years ago, and then I want to see what happened today, and then I want to look at another part of the record, and just be able to do that with gestures or ways of moving your head around. I think there's a lot we could be doing to take advantage of that. The problem is that what we have now is this electronic billing diary that doesn't have a structure for us to bring those kinds of things to bear. All it would do is maybe export data and say, do all this stuff, and now you're stuck with this thing outside that then has no way to go back to the record and say, all right, this expert system I was using told me to do this, so do it. And it'll say, well, you're the doctor, put the orders in, and start over again. So we need to find ways to bring that into the model, bring that model into the EHR so we can take advantage of those technologies. I'll go with Don and then...
Chairman, it's a beautiful presentation. Thank you very much, and the ideas are very sound and very worthwhile. My question, particularly since you've just changed locations, what sort of health professionals are prepared to follow you?
So the question is, what sort of health professionals are prepared to follow me? Well, so I think that it's both. The chairman of medicine at UAB, Seth Landefeld, is always asking me, what is it you do again, and what is tell me a hypothesis, an informatics hypothesis. But he also sends me articles that are showing, and say, hey, what do you think of this? What do you think of that? Some new technologies, and we're starting to develop some new methods for being able to review data that's in the record. And we'll be working with the medical clinics there, and we have interest at all levels. I'm on a committee that is supposed to improve the electronic health record for the system. It's not an HIT committee, it's a physician committee, and we're supposed to be looking at how we can improve the record. So people are interested in doing this. The House staff are under special pressure now to get their documentation done before they finish out the number of hours that they're allowed to work each day or each week. And so new technologies that they can use that won't be just writing these big long notes, because I was in clinic yesterday and the house staff wrote their notes. They're probably writing them now. Hopefully they'll be done by the time I can get back to my computer and go and sign them, reviewing them and sign them. But sometimes it takes them a couple of days to get to write those notes. And they will be very happy to have something that will speed that process up. And of course, the quality of the notes will be better if you're not waiting 2 days to remember what it is you.
So in other words, you're going to infiltrate the current system.
Yeah, we're going to. Don's not on microphone, but for the folks at home, Don Lindbergh is saying we're going to infiltrate the current system. Yeah, I think we have to sneak up on them. You're right. We can't just come in and say, here's a whole new system we want you to learn. What we have to do is the kinds of things that we did at Columbia, where we just added a button. And people would go, and then people would see that I had all my prescriptions printed out. And they go, how'd you do that? They go, oh, I have a button. And they go, I want that button. They go, here's the button. But the problem is you got to put your medications in a structured, controlled way. And they go, great, show me how to do that. And we went from having no medication lists to having medication lists overnight because we didn't force it on them. We just gave them an extra little thing. Hey, go read this guideline in Cimino. Oh, I can't have time. I don't have time to do that. How am I going to find it? We'll give you a little button. And you push that button, and it'll anticipate that information you need. We provide these sort of push technologies, or pull technologies rather than push technologies that shove things in people's faces. So we have to be smart about it. And again, it's a research issue. We don't just build it and stick it out there and expect they're going to use it. We have to figure out how does this going to fit in their workflow? What are the ways they're thinking? As Clem said, yeah, we clinicians think about patients in this way, and hopefully we write it in our notes if we have a time to do it. But when we don't have time to do it and we have a choice between documentation and patient care, we're going to choose the patient care time, and documentation is going to suffer. So, but you're right. We have to find ways to get this integrated in a way that's as painless as possible.
So I actually want to follow up on that point. My impression is that vendors now have a much larger control over systems of the kind you're talking about. Is there room for partnership development? Or are you suggesting the better approach is to build and find a way to flow it in and out?
So the question was, is there still a way to partner with vendors? And I think absolutely there is. And I know colleagues who are talking to folks at Epic, and I'm talking to folks at Cerner about ways that we can do this. And because the vendors are interested in improving their systems, but they're doing it in an expedient way. And sometimes it's really, what's the checklist of regulations I have to meet this week with my next version? And that's what takes priority. We need to do the informatics research to figure out how to do well. They're not going to take the time or expend the resources on that basic research. But when we have findings from it, I think they'll implement it. It took a while to get the ardent syntax out there, but now we have the ardent syntax and medical logic modules adopted by health record systems. They're fine with that. Once we tell them how to do it and what it is we need to do, then they can implement it. So there's very definitely lots of opportunity for collaboration. Yeah, Wojciech.
I actually had a similar question than Valerie. I see that our ability to modify the EHRs is diminished over time. A number of institutions who had homegrown record are now converted to. The number of questions says, what's your relationship with the IS group? And these relationships take a long time to build. So if someone is skeptical about ability to do research, and let's say even we put an open source EHR and do all our experiments in a lab, then we have to train them, and I don't think we even have a good open source EHR. So I'm skeptical that we will be able to do that basic research because we are not able to modify the systems that easily.
So it's a concern for sure that a lot of the classic great development shops have kind of gone to the dark side to a certain extent. But I can tell you at Columbia, when I left Columbia, that was the trough of despair. We were having very little impact on our ability to change electronic health records. But Columbia Presbyterian Medical Center finally realized that having a top-notch clinical informatics group was in their favor, and were able to find ways to then incorporate their efforts back in and add them as modules to the existing system. The smart on fire approach is one way that we can build things that we can at least get data out and kind of show the power of what we can do with these things if we have more information. Putting the data back in is still a challenge, and so we need to overcome that. But I think we'll get there. We're making headway on being able to write into the record from outside applications. So I think the way to do that is to build these outside applications that then the EHR vendors will go, oh, that's what we need to put in our system. Let's, instead of having it an outside thing, let's build a tab or whatever within our system that incorporates it directly into the user interface. So I think it's going to be an evolution. Yeah.
It's a short question. So well, we can take it later, but the question is really, where's the library in this? Because I think that there are a lot of players who are engaged and have been engaged since it was just utilization assessment and review in trying to identify clinical decision support modules of one sort or another. You could do it for payment, that was very simple. But the library has a role in this beyond financing research. Where do you see, what are some sweet spots for us that would be useful in particularly in this area of trying to show what's known or knowable in terms of causal reasoning?
Okay. Well, I think that some of the things the library is interested in will align with this very well. So, for instance, having repositories of knowledge and data that can be brought to bear on patient care will be critical, and the library is in that space already. And with the expansion in data science, I think is going to be a bigger player in that. So trying to figure out, we've got all this, I didn't really go into the whole personalized medicine aspect, but now a system that says, oh, you're trying to treat atrial fibrillation, then you've got to do anticoagulation, and now let me look at the genetics, and and sometimes we don't know the answers because nobody's written a paper about it, and it's not in a knowledge base, but it's in a database of patient data or repositories of genomic and phenomic data. So there's certainly places where we'll be able to tap into that. I think the library could also be trying to help us convince other institutes that some of this research is going to be needed to improve cancer care and improve kidney care and heart care, that other institutions should be picking up some of the slack here and helping us figure out how to solve these problems that's going to benefit all the caregivers across the spectrum.
I think we'll thank you for a terrific talk. If you're willing to stay, if people wish to come and question him more, that's up to you. Thank you very much.
Thank you.